Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and the Gynecology Faculty of Medicine, Mansoura University. Today we have an important topic, Isthmocele Management. We know that many cases nowadays diagnosed by transvaginal ultrasound and saline infusion hysterography as Isthmocele or cesarean section scar defect. So we wanted to know about this Isthmocele, how to diagnose and how to manage, and the risk factors, of course. So what are the objectives in this lecture? To know the definition of Isthmocele, classification, prevalence, risk factors, etiology, some hypotheses try to explain Isthmocele, clinical picture, investigations, reach the diagnosis, and lastly, the treatment. Okay, let us start with the definition. Isthmocele simply is a defect resulting from an impaired healing of both endometrium and myometrium at the site of the cesarean section. Look to this picture, please. This is transvaginal ultrasound showing the uterus. This is the body of the uterus. This is the endometrial line. This is the myometrium. This is the cesarean scar defect, or what is called the niche or diverticulum. Okay? Or Isthmocele, the topic of our lecture. So this part is called Isthmocele. This part is a defect in the myometrium following cesarean section. Okay? More detailed in definition, Isthmocele with its variable names, cesarean scar defect, niche or diverticulum, whatever the name, all of them considered Isthmocele, is defined as a myometrial discontinuity or a hypoechoic triangle in the myometrium of the anterior uterine wall. As you see here, this is the anterior uterine wall. This is the defect in the myometrium of the anterior uterine wall. At the site of cesarean section, incision, presented in transvaginal ultrasound or sonohysterography examination in non-pregnant women. Okay, this is a more detailed definition. Okay, what about classification? We have two different classification according to the size of the defect and the classification according to symptoms. Is it symptomatic or asymptomatic? According to the size of the defect, according to Maruta et al. Adopted cutoff of residual myometrium and divide this Isthmocele into large defect when residual myometrium less than 3 mm, small defect when residual myometrium is equal to or more than 3 mm. Look to this picture, please, to understand what is meant by residual myometrium. Here is the niche, okay, extending through the myometrium. This is the defect inside the myometrium. This is the proximal edge. This is the distal part. This is the apex. This is the depth of the niche. Okay, defect in the myometrium. Still remaining part of the myometrium. The remaining part of the myometrium, if more than 3 mm, so this happened in a small defect. But if the remaining part of myometrium is less than 3 millimeter, as in this case, it is called large defect. Okay? So large defect or small defect according to the residual part of myometrium. Large defect, the residual part of myometrium is less than 2.5 up to 3 millimeter. Some consider it 2.5, others say less than 3 millimeter. Okay? While the residual myometrium in a small defect, the residual myometrium is equal to or more than 3 millimeter. The other way to classify Isthmocele is it asymptomatic or symptomatic? And when it is symptomatic, it is presenting with abnormal uterine bleeding, pelvic pain, dysmenorrhea, dyspareunia, and infertility. Okay, let us go to the next, the prevalence. The prevalence of Isthmocele will be surprising to you. It ranges between 24% to 70% in transvaginal ultrasound examination. While it is ranging between 56% to 84% in sonohysterography. When you use saline infusion hysterography, the prevalence is higher than using transvaginal ultrasound alone. In women with one or more previous cesarean section, according to the study of Philander and Cohen, so the prevalence is high. What are risk factors? Multiple previous cesarean section, retroflexed uterus, making the site of cesarean section incision under traction, especially when adhesion happens with anterior abdominal wall, so leading to the defect maybe. So retroflexed uterus, multiple previous cesarean section, failure to identify all cesarean scar during repeated cesarean of multiple cesarean section. You are going to do cesarean section for a case has before cesarean section, one or more. Failure to identify the previous scar, okay, is a risk factor for development of the niche or Isthmocele. Okay. Another important risk factor is a cesarean section conducted in active labor, while cervix is dilated more than 5 centimeters. And this is usually related to larger Isthmocele. Another risk factor, when you close the myometrium with a single layer during cesarean section repair, closure with one layer may be a risk factor for Isthmocele. So we should do double layer closure to avoid such Isthmocele. Because some studies, when they compared those who did cesarean section with closure of myometrium with single layer and those who close it with double layer, the percentage of Isthmocele was more with one layer repair for cesarean section incision. Okay? Using of locked sutures associated with more Isthmocele during repair. Post-operative wound infection, and also Individual variability in healing of wound and so on can affect the occurrence of this condition. Obesity and gestational diabetes mellitus is another risk factor. Okay, what about etiology? Up till now, we don't know the definite etiology, but there are four hypotheses. We'll go through the four hypotheses. The first hypothesis concerns the location of the hysterotomy, proposing that a low incision in the cervical part of the uterus is made through cervical tissue, which contains mucus glands, and the mucus produced during healing could dilate the sutured rams of the myometrium. This is the first hypothesis. The second hypothesis is related to surgical technique concerning an incomplete closure of the uterine wall during repair. The improper closure or even no closure of the deeper muscular layer, usually unintentional. You didn't intend it, okay? Or related to non-perpendicular sutures and endometrial saving techniques may lead to an irregular myometrium closure that causing the development of isthmocele. The third hypothesis relates to early adhesion development in the stratum scar and the anterior abdominal wall. And what is the problem with that? Pulling the edges of the wound and impair the healing due to the counteracting forces on the uterine scar. And this more evident in retroflexed uterus. We know in retroflexed uterus the fundus directed posteriorly. So there is the countertraction forces will be much. If there is adhesion between the site of cesarean section scar and the anterior abdominal wall, if there is adhesion between poles, there is countertraction. This countertraction increase in retroflexed uterus. What about the fourth hypothesis? Involves patient factors suggesting the presence of an individual or genetic predisposition contributing to an impaired wound healing, poor hemostasis, inflammation, or adhesion formation. We know that people are variable. There is individual variability between people. Also, maybe genetic predisposition contributing to impaired wound healing, poor hemostasis, inflammation, or adhesion formation. This is the four hypotheses to try to explain why isthmocele happened. We should know that isthmocele has another name, cesarean scar defect, diverticulum, or niche. All these the same as isthmocele. Most isthmoceles are asymptomatic as regards the clinical picture and usually diagnosed incidentally during doing transvaginal ultrasound. What about symptomatic one? What are the symptoms? Abnormal uterine bleeding, post-menstrual spotting. The lady will tell you after the end of the menstrual flow, I found some spotting all over the days. So should take it serious. Post-menstrual spotting, dysmenorrhea, pelvic pain, and dyspareunia can happen due to different factors like inflammation, infection, adhesions, tension, pelvic congestion. Lastly, infertility. Yeah, there is a relation between isthmocele and the development of secondary infertility. What is the obstetric complication? Obstetric complication of isthmocele include placenta accreta spectrum, and all of us know that it is dangerous, and one of obstetric complications which increasing nowadays due to increased incidence of cesarean section. Placenta previa, scar dehiscence and uterine rupture due to the defect in the myometrium. Ectopic pregnancy in cesarean scar defect. So this is important obstetric complication to isthmocele. So we should take isthmocele seriously. So what is the relation between isthmocele and the secondary infertility? As regards the prevalence, the association between isthmocele and secondary infertility has been reported in the literature with high prevalence. What is the mechanism for such infertility? The presence of blood in the isthmocele could affect the cervical mucus and the sperm quality. What else? Obstruct sperm transport. What else? Make embryo implantation more difficult. All of these impairing the fertility, whatever natural or using ART. And it was found in some studies that the repair of the defect is associated with a high rate of restoring the fertility. Okay? What about investigations? Investigation to diagnose such a condition, transvaginal ultrasound is the initial and the most usual method described to assess the integrity of uterus wall in non-pregnant patients. The defect has been described on TVS as anechoic triangle defect, as you see here, anechoic triangular defect in the myometrium with the base communicating to the uterine cavity. This is the base, as you see, communicating with the uterine cavity. This is the uterine cavity. And this is the endometrial line. So, the base communicating to the uterine cavity. Or you can see deformity, wedge shape, concavity, or sacculation on the anterior isthmus. So I have different shapes. Could be wedge shape, could be square shape, could be concavity or sacculation on the anterior isthmus at the site of cesarean section incision. What else? Saline infusion sonohysterography. And you should know it is more sensitive and specific for the identification of isthmocele. As you see in this picture, through a Foley's caster, we inject saline inside the uterine cavity to do a contrast. Then with TVS, you can see the isthmocele very well due to contrast, as you see in this picture This is saline infusion hysterography, more specific and more sensitive for diagnosis. That's why the prevalence is higher when we of Isthmocele when we use saline infusion hysterography than transvaginal ultrasound alone. Another investigation, hysterography, can assess Isthmocele. However, it is not ideal, of course, for diagnosis. Both saline infusion hysterography and transvaginal ultrasound superior for hysterography. Why? It can't measure the myometrial thickness, which is a limitation of this method. Moreover, if blood or mucus is accumulated in the Isthmocele, hysterosalpingography may not clearly identify the defect. Suppose this niche is closed with mucus and the blood, so I cannot diagnose the niche or the Isthmocele by hysterosalpingography. So, many disadvantage for hysterosalpingography, so I can't depend on it because I have a better choice, which is SIS, saline infusion sonography, and transvaginal ultrasound. What else? MRI, magnetic resonance imaging. MRI allow determining the residual myometrium thickness of the Isthmocele on sagittal T2 weighted views. But you know that magnetic resonance imaging is expensive and they need experienced person, so rarely it is used, and transvaginal ultrasound and saline infusion hysterography is a good imaging technique, cheaper, and doctors well trained on it and can give me all the result I need. So rarely you may need magnetic resonance imaging to especially to determine the residual myometrium thickness. Let us go to hysteroscopy. Hysteroscopy can be used as a diagnostic and therapeutic also. Hysteroscopy enables direct visualization and the confirmation of Isthmocele, usually described as a pouch or discontinuity of anterior uterine wall. Hysteroscopy allows for visualization and the potential treatment. However, it may not assess residual myometrial thickness. So what about treatment? In case of asymptomatic Isthmocele and no plan for future childbearing, clinical observation and no surgical intervention are usually recommended. So you should divide your patient with Isthmocele into two big categories, asymptomatic or asymptomatic. An asymptomatic one, and this usually occurs with a small defect, the patient has no symptoms, has no plan for future childbearing, so clinical observation and no surgical intervention are usually recommended. But if the patient with Isthmocele is symptomatic with either pelvic pain, abnormal uterine bleeding, secondary infertility, dyspareunia, post-menstrual spotting, dysmenorrhea, the course of treatment depends upon the size of the defect and the residual myometrial thickness. That's why there are different surgical approaches and techniques to the correction of the cesarean scar defect. And there are studies running nowadays in different areas to compare different lines of treatment for Isthmocele. Okay, Expectant treatment is just follow-up for the patient. It is done only in asymptomatic women with a small isthmocele. I mean, the residual myometrium is equal to or more than 3 millimeter. Okay? Medical management with oral contraceptive can be used, aiming for what? To regulate the menstrual cycle and decrease menstrual flow, and some say it may reduce the size of the niche. However, it has been described in some studies to have failed to reduce symptoms in most of women with isthmocele. So, it is not a good choice if you compare it with hysteroscopic resection of isthmocele, for example. Hysteroscopic resection of isthmocele is a minimally invasive, non-time consuming, low morbidity procedure, allow visualization and the repair of the defect. The surgical technique overall consists of the resection of fibrotic tissue from the defect, presented like a flap underneath the triangular pouch. Also, the resection of niche edges setting the wall in continuity to the cervical canal improves the flow, drainage, and the prevent retention of menstrual blood. This is important also. What else in hysteroscopic resection of isthmocele? I can do fulguration of the base of the pouch, entire, either globally or targeting the visible vessel, enables the removal of the inflamed and the congested tissue, preventing the in situ production of fluid and the blood. And nowadays, in a running studies, there is a progressive agreement in recommending hysteroscopic repair of isthmocele as a first choice approach as long as the residual myometrium thickness is at least 2.5 up to 3 millimeters. Okay? What about laparoscopy? Is it has a rule in isthmocele repair? Yeah. Laparoscopic approach has been advocated for large defects, especially when residual myometrium is less than 2.5 millimeters. So the defect is large, residual myometrium less than 2.5 millimeter, and there are symptoms like normal uterine bleeding, pelvic pain, infertility. Laparoscopy enables a better visualization to identify the defect, allowing repair and thus increasing the myometrial thickness. Laparoscopic isthmocele repair include resection of isthmocele edges to excise the scar tissue and closing the defect in two layers. Okay, closing the defect in two layer suture after excision of the edges and the old scar. Another line of treatment which is very interesting and very nice is the vaginal procedure. Vaginal procedure to isthmocele repair is a minimally invasive and effective technique, but need experienced person, gynecologist in the field of genitourinary system. This technique is described as dissection of the bladder from the cervix and the uterus. First, we do dissection as if we are going to do cystocele like that. We dissect the bladder from the cervix and the uterus. Then, opening the vesico-vaginal space, identify the isthmocele. Then the defect is excised and hysterotomy is closed in 2 layers. This is the vaginal procedure, and it is very nice, can be done easily within short time, and considered one of the minimal invasive surgery. Lastly, the hysterectomy. Hysterectomy is the curative management for large symptomatic isthmocele in women who don't wish to conceive anymore, especially in those above 40 and they completed their family and she don't want more children, and the isthmocele is symptomatic. Yes, hysterectomy could be a line of treatment. Yet, hysterectomy is a major procedure when compared to other minimally invasive approaches available. So, if you compare hysterectomy with a stereoscopic resection of isthmocele, stereoscopic resection of isthmocele is the less invasive, is a minimally invasive surgery, taking a very short time with less complications. Okay? But if the patient decides to do hysterectomy because of the severity of the symptoms and she don't want more children and the defect was large, it is better to do laparoscopic hysterectomy rather to do laparotomy and hysterectomy. Okay, so you can use one of the minimal pelvic surgery like laparoscopic hysterectomy better than to do laparotomy. Okay, this is the end of my lecture today. I hope it was beneficial for you. I want you to know that many researches are running nowadays about isthmocele and comparison between different lines of treatment, and also searching for why it happened, because up to now we have 4 hypotheses or more trying to explain why it happened, but definite etiology and the definite guidelines up to now not developed as regard the diagnosis and the management of isthmocele. And we should know that isthmocele has a relation to infertility in one side and also to some obstetric complications like placenta accreta spectrum and scar ectopic, cesarean scar ectopic, and the placenta previa, and all of these are hazardous and life-threatening conditions. Thank you, everybody, and wishing you all the best. I'll put in a comment my site on YouTube where you can find more lecture in OB Guide and the quizzes, case scenario discussion, guidelines. Also, I'll put in a comment my site on Amazon as an author for these 6 books. I hope each book of these can help you in OB Guide. Thank you. Wishing you all the best.